sono Lidia Poet. stamattina mi ha detto Carlo che aveva bisogno del permesso della registrazione del professor Myles. Carlo mi sente. Insomma, l'abbiamo avuto da parte del professor Myles, quindi non ci sono problemi per la registrazione in YouTube.
Ok, professore, d'accordo.
Carlo sta parlando da casa però questo sfondo non mi piace perché
lei è al nord, dove sono andato?
il santo protettore.
Buonasera.
Che cambio il fondo. Adesso non mi ricordo più dove è qua lo sfondo, ma comunque.
Mi sentite indifferita su...
Sì, sento una voce di fondo, sì.
C'è una musichetta di fondo.
Sì. Mi sentite indifferita su YouTube, tutto quello che dite?
Ah.
Sì.
Sento una voce di fondo, sì.
C'è.
Il canale YouTube è stato collegato sul totale?
Sì, ce l'ho aperto sul telefonino.
Visto che siamo già a 40, il regista può partire con l'intervallo. Prego, regia. Vabbè, mi scollego. Stiamo aumentando. Tu Emanuele la senti? Non la senti.
No, professore, neanch'io veramente.
Sì,
ma non
sì,
so
sì,
se-
sta arrivando la musica comunque.
Ah, perfetto. Allora, meno male.
Almeno su YouTube c'è già.
Ah, è sempre quello.
Ma noi in Teams
tempo.
non lo sentiamo però.
Poi casomai lo sentiremo registrato. Adesso presento.
Ah, ecco, abbiamo. Va bene. Ciao Sergio. Emanuele, possiamo invitare il professore Myles?
Sì, subito.
Perfetto.
Sì, ce l'ho fatta.
Eccoci.
Welcome, professor Myles. Allora Sergio, puoi
Welcome.
andare? Sì, sì, il professor Myles è collegato, lo potete vedere anche voi.
Quindi possiamo già iniziare?
Sì, sì, sono le 5, quasi 3.
Perfetto.
E siamo in... Perfetto, possiamo iniziare.
Good afternoon, professor Myles. Benvenuti a tutti e buon pomeriggio. Siamo particolarmente lieti di avere questo ospite che è frutto naturalmente dell'interazione molto proficua del professor Settineri e del gruppo della terza missione, che evidentemente affronta un tema di estrema importanza, che evidentemente attiene a tutti noi perché lo siamo stati, perché abbiamo evidentemente guardiamo sempre a una particolare fase della nostra vita che offre delle criticità che vanno interpretate, analizzate e ovviamente gestite con la conoscenza e la competenza che a giudicare dal curriculum che il professore Settineri ci ha mostrato, il professor Myles sicuramente evidentemente esprime ed esprimerà. Soprattutto però permettetemi di salutarlo, giusto 2 parole, just 2 words for Professor Myles. It's a pleasure for me, and I would like to thank him for accepting the invitation of our department, and also for his contributions to our department's program. I'm sure that Professor Myles will also a lecture really interesting and very useful for everyone. We are waiting with attention. Thank you so much again, and have you a nice afternoon. Bene, vi saluto tutti e vi ringrazio ancora per esserci. Passo la parola alla nostra guida in terza missione, il professor Settinelli. Bene.
Grazie Sergio. Allora, benvenuti tutti quanti, ci ascoltano. Grazie per questo, di aver partecipato a questo evento. Anch'io dirò qualche parola in inglese. Dear audience, thank you for coming. Thank you for inability the virtual reception space with our events. The topic dedicated to adolescents is of general interest because not everything to do is just because they are teenagers. Thank you, Professor Myles, for your report, and we are happy for this experience. Adesso passo la parola al conduttore, molto più bravo di me in inglese, il dottor Merlo, nonché journal manager della nostra rivista Mediterranean Journal of Clinical Psychology.
Ok, grazie a tutti. The contribution is titled A Critique on Psychiatric Diagnosis. Professor Myles is currently working at the Oxford University at the Department of Experimental Psychology, previously working for the NHS, Durham and Cambridge University. The theme of diagnosis is analyzed through different keywords, as in the case of the role of clinical psychology in psychiatric diagnosis, and with particular reference to some themes and issues related to nosography, as in the case of comorbidity and poor reliability of diagnosis, through the need for a better understanding of mechanisms underlying psychopathology, the onset, the maintenance of syndromes, as well as for clinical, I would say, and chronic conditions. So this intervention will present and take into account past current research supporting necessary criticism on past, present, and future directions for clinical psychology. So now we will be grateful to listen to your presentation, so I invite you to proceed with it.
Hello, thank you very much for the warm introductions from Dr. Merlo and all the other professors. I'm just going to share my screen. Can you all see my screen?
Yeah, we're able to see it.
Excellent stuff. Great. Okay. Well, I mean, thank you so much for the very warm introduction. It's a real pleasure to be here today. And it's only a shame that we're doing this this virtually. It'd be so lovely to be there in person with everyone and meet you all. But yeah, today I'm gonna provide a critique on psychiatric diagnosis, and I'm gonna really try and tie it to developmental psychopathology, because I know that's what we're here to discuss today. And but before I start, I always feel it's important to thank the organizations that have helped me along the way. So I've previously worked at the University of Durham, University of Cambridge, and now in the clinical psychology department at the University of Oxford, and I've worked with various NHS trusts as well, National Health Service trusts as well. So yeah, it's lovely to be here. What I would encourage people to do is I've left room in these slides for questions. So if anyone has any questions as we go along, please feel free to stick up your hand in the raise your hand function, and yeah, I'd be delighted to take them. Alternatively, if you'd prefer to keep your questions for the end, then that is of course absolutely fine. So we'll crack on. To offer an overview of what I'm going to talk about today, I'm going to give a very brief overview of the history of psychiatric diagnosis. So this is the predominant framework which underpins a lot of what we do as clinical psychologists. And then I'm going to go on to discuss some of the scientific issues with this. And I'm going to be really specific about the scientific issues rather than the clinical and political issues. Following on from that, I'm going to discuss what I hope for the future of clinical psychology, discuss my vision of this, and I would encourage you to critique my vision. My vision is by no means the right vision, so I really welcome alternative thoughts, and I'd love to hear your thoughts about what you hope for the future of clinical psychology. And I'm going to give examples from my own research and work that I've done with Dr. Merlo as well along the way. So we've worked together for a couple of years now. So I'm sure everyone will recognize these. These are the diagnostic manuals which pervade clinical work. So on the left, we have the DSM. That's predominantly the American manual that is used to diagnose mental health difficulties or mental disorders, as they're referred to. And on the right, we have the ICD, which is more European version of this. Now, the reason I present these is I want to go back in time. So if you go back to the early 1800s, that was when the idea of diagnoses first intercepted theory. And at that time, we had two core diagnoses. These were psychoses and neuroses. Now, the difference between these was largely based on severity. So if someone had a more severe difficulty, then they would meet a higher level of diagnosis compared to the lower. But of course, there's a degree of subjectivity in that. Now, the reason this comparison is important is that nowadays, in the DSM, for example, we have nearly 400 diagnoses, and this is only increasing. Now, I think the increase in the additions of diagnoses to the manuals increasingly begs questions of validity and reliability. And I'm going to discuss some of those in a moment. But before I do, I just want to start by saying, even though I believe that there are issues with validity and reliability of diagnoses, I think they serve a rather excellent clinical function. For example, if you tell someone that they have a particular mental health difficulty, such as depression or something like that, it can be very validating. It removes the responsibility for their struggles from them. And I think that has immense power. So I don't want to detract from the clinical benefits of it. Nevertheless, I think that you can achieve those same outcomes without having to appeal to diagnostic frameworks that perhaps lack scientific validity. So
your microphone is off. Sorry.
Oh, sorry, I accidentally switched off my microphone. Can you see the slides moving okay?
We do.
Yeah, great stuff. Okay, yeah, so I'm going to work through gradually the issues that I see with the scientific validity and reliability of psychiatric diagnosis. And I think one of the things that I really want you to keep in mind whilst I'm talking about this is the aim of diagnosis. So Jeffrey Lieberman was the former director of the American Psychiatric Association, and he was fundamental in the development of the DSM-5, the most recent edition of the Diagnostic and Statistical Manual of Mental Disorders. And what he says is that we are actually looking for prominent syndromes in nature that are truly there. So this takes a very positivist framework of reference. We are looking, when we are diagnosing mental health difficulties, we are looking for things that are truly there and reside in nature. And my proposition today will be that they aren't truly there in nature. So the first issue that I see is that there's a high comorbidity rate between diagnoses. If you have some form of diagnosis, say depression, then you're actually far more likely than you would expect by chance to have another diagnosis, whether it's anxiety, schizophrenia, wherever it might be. Now, if these were distinct constructs in nature, i.e. depression is a phenomenologically distinct facet than anxiety, then what you would expect is that there shouldn't be any crossover, or if there was, there should be some theoretical explanation for this, but there isn't in terms of psychiatry. Clinical psychology has come up with theories as to why there's comorbidity, but psychiatry hasn't, or at least not convincing studies. Now, another issue with diagnoses that I see is poor reliability, and there are two forms of reliability in which it's weak. The first is test-retest reliability. So test-retest reliability, just to remind everyone of their statistics, is the reliability across time. So if I take someone at time 1 and I diagnose them with depression, 6 months later, if I look at them again, then they're unlikely to have depression. Then they're more likely to have something else like anxiety, OCD, whatever it might be. And this I see as a real problem because, again, if these are distinct phenomena, as Jeffrey Lieberman posits, then it shouldn't be the case that that they're changing over time. In addition to this, there's poor inter-rater reliability. So, for example, when you have disorders such as schizophrenia, the inter-rater reliability, so this is the agreement between clinicians when they're diagnosing, is about 0.46. So that's essentially just a correlation. And when you look at the inter-rater reliability for mood disorders, so depression, anxiety, that kind of thing, the reliability falls to 0.25. Now, this is extremely low. If we had a questionnaire that was having this kind of reliability, we'd be putting it straight in the bin. So I see that as a real problem. Another issue that I see is that it doesn't, diagnoses don't really tell you much about what you can expect. They don't determine the prognosis. If someone has a diagnosis of anxiety, for example, that's pretty poor at predicting what's likely to happen when compared to other mental health difficulties. So if you know someone generally has a mental health difficulty, then that does predict that they will have things such as poorer quality of life, lower perceived control, and so on, as compared to someone without a mental health difficulty. But when you're looking at the specific diagnoses, they have very limited predictive power. Again, I see that as an issue. You would expect that if these diagnoses were independent, they should predict different outcomes. And similarly, the diagnoses don't often have obviously different causes. There's a lot of overlap in the kind of factors that cause depression, anxiety, OCD, schizophrenia, whatever it might be. There's a lot of overlap in the causes of this. And I think psychiatric theories do pretty poorly in explaining why someone would present with a different condition. Clinical psychology theories, on the other hand, they have their own problems, but I do think they do better. Again, one of the additional issues is that they have a limited appreciation of symptoms varying on continua. So there's a real categorical sense with diagnoses. There's you either have depression or you don't, or you either have anxiety or you don't. And this, again, I see as an issue because most symptoms vary on dimensions. And actually, when it comes to diagnostic categories like depression, it's multidimensional. There are lots of different symptoms you can have of depression, and you can be spread in these to varying degrees. So again, that favors a multidimensional perspective of mental health difficulties, which is largely absent from psychiatric diagnosis. Now, there are some exceptions. One of which is, of course, autism spectrum disorder. That is conceptualized as a continuum, which I think is progress. And in addition, in the most recent revision of the DSM-5, they have an appendix which specifies that many of the mental health difficulties can be conceptualized in a continuum. So this is progressing. But again, I think it's too slow. Now, the next issue that I see is the overemphasis, despite the limited understanding of biology. I think this is the fundamental problem with contemporary diagnostic frameworks, such as the DSM. So what, as I highlighted at the beginning, what Jeffrey Lieberman was looking for were these prominent syndromes that are present in nature. And the DSM-5 was built upon what they thought was a biological understanding of psychological difficulties, of mental disorders. And I think this is fallacious. I don't think we do have any understanding of, well, I think we have very little understanding of how the mind works at a biological level. I think we have even less of an understanding as to how mental health difficulties operate biologically. And therefore, I think that we shouldn't be creating frameworks based on something with which we have a limited understanding of. And again, one of the reasons that I feel it's so important to discuss this is that billions of dollars of investment are put into understanding the biology of mental health difficulties, and it's a failing field. It really is. And I know that might sound quite strong, so please feel free to disagree with me on it. And you know, one example is the likes of genes. Genes account for an extremely small proportion of the variance in mental health difficulties, and despite this, people are pummeling huge amounts of money into this, into genetics research for mental health difficulties. And you know, I'm going to quote the cross-disorder group of the Psychiatric Genomics Consortium here. They say that the effect sizes of genome-wide significant loci are individually quite small, and the variance they collectively account for is insufficient for predictive or diagnostic usefulness. So essentially what we're saying there is that genes have a bit of predictive power when it comes to determining whether someone has or does not have mental health difficulty, but it really doesn't tell you anything about what kind of difficulty they're going to experience. So to me, that is not evidence that biology plays a role in, for example, schizophrenia. Another issue is that, similarly, just to follow up, Thomas Inso, who some of you may know was the former director of the National Institute of Mental Health, he spoke out about this. So I'm going to quote him here. He said, "I spent 13 years at the National Institute of Mental Health, really pushing on the neuroscience and genetics of mental disorders. And when I look back, I realized that I think I succeeded in getting lots of really cool papers published by cool scientists at a fairly large cost, approximately $20 billion. But I don't think we moved the needle in terms of reducing suicide, reducing hospitalizations, or improving recovery for the tens of millions of people who have mental illness." So again, just to reiterate, this is such a problem because we're spending so much money on a field that is not helping people, and it's public money as well, which compounds the issue. And finally, the issue that I see with all of this is that symptoms rarely indicate the course of treatment with any specificity. If someone has a whole array of if someone meets the criteria for a multitude of different diagnostic categories, generally the course of treatment that's indicated by NICE guidelines, for example, is CBT. So there isn't really specificity. For example, it's not the case that we know that if you have OCD, you should have psychodynamic therapy. If you have depression, you should have CBT, and so on. It's quite general, and even the formulations that we use for those models are overlapping. So that's a broad overview, and it's quite a scathing critique of psychiatric diagnosis. And I do hope no one takes offense at that. And I encourage you to share your critiques of me. If you disagree with my points, that really would be welcomed. But of course, you know, it's no use me turning around and saying that there are all these issues with psychiatry without proposing any solution as to what I hope for the future. So what I hope for the future of clinical psychology has been sort of briefly touched on in this paper, which was published in the Mediterranean Journal, which I worked on with Emmanuel. I think what clinical psychology should begin to do is focus on the individual mechanisms governing cognition and behavior more generally, and then look at how aberrations in those mechanisms can result in mental health difficulties. So to give an example, we know that there are various cognitive mechanisms such as episodic memory. A lot of people, unless they've had a particular brain injury or stroke of some description, a lot of people will have episodic memory, they will learn by associations, these kind of things. We know there are these domain general mechanisms that underpin cognitive functioning, and I think aberrations in those mechanisms or variations in those can result in mental health difficulties. Now, I actually think this is philosophically, this makes more sense, because what we're doing is we're looking at what mechanisms do we know underpin cognition, and how do changes in those result in mental health difficulties. If you think about how research usually works, it comes almost backwards. It has the assumption that something like depression exists in nature, and then it tries to look backwards to see what might have caused it. But this first assumption that depression exists in nature could be erroneous. And again, just to make this point, one statistic which I came across in a paper by Andy Scull, who some of you may know, he's over in the US. He cited that because of the many criteria for meeting a diagnosis of depression, there are over 16,000 different ways that you can meet that criteria, specifically 16,400. Now, I think it seems ridiculous to suggest that all of those different presentations of depression are underpinned by the same factor, whether it's an aberrant gene or some sort of affected neural pathway. I think that seems absurd. So I think it makes much more sense to go at it this way, in terms of looking at what mechanisms generally operate in humans and how do aberrations in those result in mental health difficulties. So that's my sort of logic with it all, and I'm going to give you some examples from my own research as well along the way, really tying this back to adolescence and psychopathology during development as well. So one of the areas of research that I was quite involved with back at the University of Durham was research on empowerment and autonomy. So early work from Linda Bramson and Martin Seligman advocated the importance of perception of control in psychological welfare. And indeed, what the research tends to show is that, oh, sorry, I think I heard, was there a question? I think I heard someone's microphone.
No, I don't think so.
Don't think so. All right, cool. Oh, grand. Well, if there are any questions, feel free to stick up your hands. I'm more than happy for people to interject. But yeah, so where was I? Linda Bramson and Martin Seligman, they initially did some work in perceived control, and they argued that low perceived control can result in a variety of mental health difficulties. Now, if you try to look at this from a very mechanistic perspective, such as what I was describing before, you might say, well, what is control? Control might be conceptualized as the perceived contingency between one's actions and an outcome. So it's kind of like a correlation between action and outcome. And we did some work in this at the University of Durham, and what we showed was that people do perceive, they generate correlations in their head. They perceive the extent to which outcomes are contingent upon their actions, and they deduce a sense of control from this. And that sense of control then informs the manifestation of low mood. So what we found was that if you have low mood, if you have a low perception of control, that can result in elevations in low mood. Now, the work went a little bit beyond this, but that has important clinical implications as well. Before I go into the clinical implications, we also did some work in desire for control. And again, this gets a bit philosophically quite difficult to conceptualize in this mechanistic way, but I wanted to mention this here because I think this is really important for the developmental psychopathology side of things. And one of the papers that Dr. Merlo and I worked on was we talked about how incongruences between desire for control and perceived control can result in poor mental health. So we wrote one paper postulating that one of the reasons adolescents may show an increase in mental health difficulties is that adolescence is a time of growing desire for control. Typically, adolescents will continue to try to exert increasing amounts of control. Now, they are often afforded greater actual control as well, but what we argued in the paper is that those who are struggling more, there's a greater incongruence between their desire and their perception of control, and specifically, they have elevated desire in the absence of perceived control. So anyway, returning to this quite computational perspective on perceived control, I said that it was the contingency between actions and outcomes. Now, if you think about a general correlation, of course, we're all trained in statistics, we can think in this way. There are various events which might influence a correlation. You can have an event where an action leads to an outcome, or you can have an event where an action leads to the absence of an outcome. Alternatively, you can have an event where the absence of action leads to an outcome, and finally, where the absence of an action leads to the absence of an outcome. That is what formulates our correlation. Now, this has important clinical implications because you have to remember that true control is not the same as perceived control. And this is where it's critical, because the way in which we derive perceptions of control is not equally weighted in those 4 types of events that I just described there. And actually, our perception of control is most influenced by the events in which an outcome follows an action. So again, that's really interesting, because what that suggests is that even if you don't change someone's true control over the world, you can increase their perception of control. Now, given that perceived control is important for empowerment and other mental health difficulties, that's a really important thing, a really important finding. And indeed, this was consistent with the research that we were doing at the time. And what this essentially means is that if someone is feeling quite disempowered, which might be resulting in symptoms of depression, symptoms of anxiety, whatever it might be, essentially all you have to do is get them doing more. And their perception of control should increase according to this theory. And indeed, there is evidence for that. And we posited that this could be an explanation as to why the likes of behavioral activation works. Behavioral activation being trying to support clients or patients to just do more in their daily lives. So that's one example from work I did at the University of Durham and later with Dr. Merlo on how these ideas about associative learning that are generating, perceiving contingencies between actions and outcomes can inform mental health practice, clinical practice. I'm going to now move on to talk a bit about some work that I did with the University of Cambridge. So I was working last year with the University of Cambridge on a project around hallucinations and unusual beliefs. Now, as I said at the beginning, I spoke quite passionately, I would say, about how I disagree with the validity, or well, I think that psychiatric diagnoses have limited validity and reliability. However, much of the research in this area is based on the idea of schizophrenia, so I'm going to talk within that framework. So a diagnosis of schizophrenia is typically made because an individual experiences hallucinations and unusual beliefs. Okay, and unusual beliefs might be referred to as delusions. So one of the popular theories by Kshitij Kapoor, who's now at University College London, that he developed about 20 years ago, was this idea that people with schizophrenia maintain greater attention to stimuli that they should have otherwise habituated to. And this is known as the salience hypothesis. So there's an assignment of aberrant salience to stimuli. The extent to which something is attention demanding is unusually high, is sort of what this theory says. Now, there is evidence for this, but much of this evidence is limited, and is limited by confounding factors that I won't go into because I don't want to bore you too much. But what we wanted to do was try and create a paradigm that is free of those confounding factors. I'm so sorry to interrupt everyone. I can just hear a wee bit of feedback on my end, so it'd be amazing if everyone could just check their microphones are off. So in this study, it was a very large sample, 260 participants. We powered it very well. It had over 90% power. We wanted to be really sure that what we were claiming from our study was valid. And we gave our participants several measures. I won't go into these too much. Essentially, one of them was a measure of unusual beliefs. One was a measure of hallucinations or hallucinatory experiences. And we gave people a perceptual learning task. Now, some of you might be familiar with perceptual learning tasks. They're not that popular, but if you have come across them before, hopefully this should make a wee bit more sense. But what they do is they assess two things. One, they assess the attribution of salience to stimuli. How much attention do we pay to stimuli out in the world? And two, what they assess is something called conditioned inhibition. So what conditioned inhibition is learning that a stimulus leads to the absence of an outcome. So it's like learning a negative correlation. I hope that makes sense. So it's not just learning that something's uncorrelated, it's learning that a particular stimulus specifically signals the absence of an outcome. So we gave our participants these measures, this task, and we found some really interesting results. So what we found was that unusual beliefs are associated with the attribution of greater salience stimuli. So what this means is that stimuli that we should naturally habituate to, that should fade into the background of our attention, people with bizarre beliefs, such as those with the diagnosis of schizophrenia, they attribute greater salience to these stimuli on average. Now, that's really interesting. And we began to think about what is the explanatory link? As I said, I want to move clinical psychology towards thinking about the mechanisms contributing to these phenomenological experiences that we call mental health difficulties. And one of our theory in this, and again, I welcome your thoughts and your ideas, is the following. We think that where beliefs come from is their associations. We think that all a belief is a perception that two things are linked via association. And indeed, Dr. Merlo and I also wrote a paper in this recently, discussing the sort of philosophical foundation of what is a belief. Now, what this might mean is if you attribute greater salience to stimuli, well, salience is fundamental in the formation of associations. I'm sure we all remember that from our undergraduate days, learning about associative learning and Pavlov's dogs and the likes. And yeah, that's important because if you attribute greater salience to stimuli, they might more readily become associated. So if I pass a red door in a blue car in the street, I might more readily form an association between those two things, thinking that every time I see a red door, I'm going to see a blue car. Now, the issue with that idea is that we have this natural mechanism, conditioned inhibition, which abolishes association. So if we begin to associate a red door with a blue car, when we come to see that a red door is on its own, it's not accompanied with a blue car, then we should, abolish that association. What should normally happen is that we learn that actually, no, it was just by chance. Red doors aren't associated with blue cars. But what we found in our study was that unusual beliefs were also associated with impairments in conditioned inhibition. So what you have here is essentially, to use a metaphor, a sort of perfect storm of impairments that can lead to the arising of unusual beliefs. Essentially, you have an increased propensity to form associations, and you have a reduced ability to correct them when you've formed erroneous associations. That, to me, is the perfect storm for unusual beliefs, if you believe that associations are what unusual beliefs are, which at the moment I do, although I have my reservations in this. In addition to this, we found that hallucinations are associated with elevated salience. So, reductions, apologies. It's associated with reductions in the attribution of salient stimuli. Now, this was weird. This was a weird result. No one had found this before. And as I said, I'm confident that that result is correct. Our study was very well powered. It had 260 people, but I don't know why that happened. And I have some ideas. And I won't bore you with those ideas now. But what I will say is that I'm actually following up that finding with research with researchers now at the University of Oxford, which is where I'm currently based. And some of you may know the likes of Louise Johns and Professor Paul Salkowskis and Professor Myra Cooper. I'm doing work with each of those to try and follow up on this result and figure out, why is that the case? And again, tying it back to adolescence, we see that symptoms that are associated with diagnosis of schizophrenia, they tend to develop in later adolescence, and understanding where aberrations in those mechanisms might come from in adolescence is so fundamentally important. Unfortunately, my results don't extend that far. Our study did not look at that, but this is something I would like to see future research in. What is it about the experiences of adolescence that results in aberrations of these mechanisms? So to conclude, what I've the case I've made today is that I think clinical psychology should focus on the mechanisms governing cognition generally and behavior. And I think that what we should do is begin to look at the influence of individual differences on these and where those individual differences come from. Why is it that aberrations in these mechanisms result in mental health difficulties? Now, before I end, I think it's important to finish off with some caveats. The first of these is that I have strongly critiqued psychiatric diagnosis today, but I've done so from a scientific standpoint. I do think the power of psychiatric diagnosis is very weak from a scientific standpoint, but I think the power of it from a clinical and political standpoint is huge. As I said at the beginning, diagnoses can help people to make sense of the experiences they're having. They can help to make sense of, they can help to remove responsibility from what's happening. That can be so important, particularly for people who perhaps don't maintain much compassion from themselves. I'm thinking of the likes of Paul Gilbert's work in compassion-focused therapy. And they're also practically necessary to receive support in our healthcare systems. I know in the UK we have the National Health Service. I know in Italy, I don't really understand this, I must confess, but I believe you have some sort of system where you rank the extent to which people are struggling with their mental health in different points. Yeah, I recently learned of this as a bit of a side note. I recently learned of this because I'm going to Rome in a couple of weeks, or next week actually. Yeah, I was learning all about this. But anyway, the point is that I know that we need these diagnoses at the moment to support with these political and clinical necessities. But that said, I don't think this is the only way of doing it. I think we can do better. And again, even though I have spoken critically of some research, including genetics research, advocating the importance of the research I have is not intended to undermine the importance of other areas of research. And I do see that these people are doing really good work, and it is enlightening in lots of ways. But the primary issue that I see with it is that we're pummeling huge amounts of money into it, and we're not really getting much back. And I think that's a problem. Yeah, so I guess I've finished up quite quickly, actually. I finished up faster than I intended. But yeah, I just want to finish off by saying thank you very much for listening to me ramble on. It really is such a privilege to be here speaking to you all today. And yeah, hopefully if we do this again in the future, we can do it face to face. But yeah, no, I want to say again, thank you to the National Health Service organisations that support me. Thank you to the universities that support me. And thank you to you all for listening. I'm happy to take any questions now if that would be of interest to people.
Ok, se abbiamo domande possiamo procedere. Prima di passare alle conclusioni.
Hello, can you hear me? I have a question.
Yeah, I can hear you well.
Okay, my question is, some of these scientific issues that we have with psychiatric diagnosis, at least in part, can be applied to other fields of medicine, or do you think that is something very specific of psychiatry?
That's an excellent question, and one I get asked quite a lot. I think the important caveat before I answer that question is to say that my knowledge of other fields of medicine is really quite poor. So because of that, I would say that I'm definitely not the best person to answer it. However, from my understanding, I think other fields of medicine are different. I think this philosophy, this diagnostic philosophy, works quite well in a lot of other areas. But again, I think that's because if you have, for example, heart failure, you understand the causal basis of the heart failure. We don't determine a heart attack based on someone sweating, someone having clammy hands, someone feeling lightheaded. We determine it based on a blocked artery. So we understand the mechanism that's led to it. Essentially, what I'm arguing is that we should have a parallel system in mental health, but we use a bit of a backwards deduction to understand mental health difficulties. We look at the symptoms and then try and infer the cause. So I would say that in other medical professions, from my understanding, I don't think this is as much of an issue. However, as I say, I don't really know much about other medical fields. But thank you very much for the question.
Thank you.
Altre domande? Okay, so now it's time to introduce Professor Muscatello for conclusions.
Must I open up my microphone? Yes. You hear me? I'm very enthusiastic to hear about this lecture because it really has touched the main problems we have in psychiatric diagnosis. We are not very comfortable with actual categorical systems. This is the very first thing that I introduced to my students when I had the very first lessons of psychiatry course. The dimensional vision is more a real world functioning. So it's not easy to make a diagnosis, but studying dimensions is more realistic, I think. And also the issue of salience is very, very important in psychiatry, not only in psychosis where it was born, but also in, for example, we studied it in some personality disorders as well. For example, those with a traumatic origin, borderline. In effect, trauma, early trauma, usually disrupt salience network. So this is so in psychosis and schizophrenia in ultra high risk populations, and also in those spectrum disorders that are not so manifest, so visible, such as cluster A, for example, personality disorders. But when there is a psychotic dimension, and the salience in the delusion genesis is very, very important, because delusion in this framework may be a top-down cognitive explanation that the individual imposes on these experiences of aberrant salience in an effort to make sense of them. So I'm very thankful to Professor Myles, because the topics he has faced this evening are fundamental for psychiatry and for medicine in general. Well, the things are very similar, I think.
Yeah, thank you so much. I'm so sorry, my connection was dropping out a bit there, but it sounded really interesting. I agree with everything I heard. Slightly, the Oxford Wi-Fi is terrible, but thank you nonetheless.
So thank you, Leon, for your thorough presentation.
Thank you for organizing this, Dr. Mello. It's been a real pleasure to come and see you all and speak to everyone today. I can't thank you enough, and I only hope that I didn't bore people. That's my only hope.
No way.
Absolutely. I think this is not a peril, not a danger. We are really fascinating. Yes. I think that I meet the thought of many of us.
Ok, professore Settinelli, microfono.
Thank you for your lecture. I hope to ready your research in our journal.
So, thank you again, Leon. And we hope to see you soon.
Grazie a tutti gli altri che ci hanno ascoltato. Vorrei ricordarvi che il professor Myles ha messo a disposizione la registrazione di questo incontro sul nostro sito di terza missione, che ha un appendice in YouTube che raccoglie tutte le nostre attività di terza missione. Questo lo dico per quanto riguarda i giovani studenti che vogliono fare qualche comunicazione su questo tema. E naturalmente sono sicuro che la prossima volta sarete sempre di più e con nuovi e diversi argomenti. Anzi, vi posso preannunziare che il prossimo grande evento sarà verso la fine del mese di maggio, dedicato al rapporto tra clima e disturbi medici. Grazie.
Ottimo, buona serata.
Buona serata a tutti. Grazie, grazie alla professoressa Moscatello, grazie al professore Merlo.
Take care. Wonderful to see you all. Bye.
Bye bye.
Bye.
Bye bye. Many thanks.